My name is Bruce Campbell. I'm a stroke neurologist and chair the Clinical Council of the National Stroke Foundation. I'm going to be discussing the National Stroke Audit of Acute Services 2015. Stroke is one of Australia's biggest killers and a leading cause of disability. This year it's estimated there are almost 50,000 new and recurrent strokes and over 35,000 hospital admissions due to stroke in Australia. The cost burden of stroke is estimated to be about $5 billion a year to the health service. The National Stroke Audit of Acute Services is a National Stroke Foundation initiative and is part of its commitment to promoting the delivery of evidence-based care for stroke. It first commenced in 2007 and is conducted biennially. The audit is provided in two key parts: the results of a survey completed by 185 hospitals outlining the resources, processes and infrastructure to support best practice stroke care, and a retrospective audit of over 4,000 patient case notes reporting care against the quality statements contained in the Acute Stroke Clinical Care Standard. We hope that the results of this audit will be used to inform planning at a local, state and national level in order to improve the care delivered to patients with stroke. This video outlines the key findings found within the 2015 National Report, which is available to download at the National Stroke Foundation website. The Acute Stroke Services Framework aims to improve the quality of Australian acute stroke services by outlining recommended structures, networks, settings and criteria for monitoring. Now, in this year's organisational survey, only one hospital was found to have all the 24 elements required for a comprehensive stroke service. There were 10 hospitals who had 10 or fewer of the framework elements, and the median number of elements was 18, a figure which increased with the volume of stroke patients admitted. Smaller hospitals were also more likely to have fewer of the key framework elements such as a stroke unit, the routine use of guidelines, care plans and protocols, or a dedicated stroke coordinator position. Hyperacute services is the care that a patient receives within the first 1 to 2 days, particularly after admission. Stroke unit care is recommended for all hospitals providing stroke care. The differentiating criteria between a primary and a comprehensive stroke centre is the provision of 24/7 hyperacute treatment, which includes both endovascular and thrombolysis services. There are 19 large hospitals providing an endovascular service across Australia, but it's not available 24/7 in almost half of these. In some states, there is no endovascular service available at all. The number of hospitals providing thrombolysis and the number of patients receiving it remains steady over the last 4 years, but compared to international benchmarks, the rate is low and the median time to deliver that therapy, called the door-to-needle time, was poor. Relatively few patients receive thrombolysis in private or smaller hospitals, which is an issue we need to address. In terms of stroke units, the proportions of patients accessing a stroke unit across Australia did improve slightly from 58% in 2013 to 67% in 2015. However, only 39% of patients spent at least 90% of their acute hospital stay on the stroke unit, and this is compared to 83% of patients in the United Kingdom. The key factors that influence stroke unit access appear to be the location of the hospital. We had 9 hospitals admitting over 75 patients a year that did not have a stroke unit. Capacity: there are several hospitals that did not have enough stroke unit beds to manage all their patients on the stroke unit, whereas other hospitals reported more capacity than was needed. Bed management is an important issue. On the day of the survey, 32% of stroke patients in hospitals with a stroke unit were actually not on the stroke unit, despite the availability of 257 beds. This year's organisational survey highlighted the fact that many of the stroke units in Australia failed to meet the minimum criteria outlined for a stroke unit. The greatest contributor to this was the absence of a dedicated medical lead, and therefore these hospitals provided an incomplete specialised multidisciplinary team. Regional responsibility in telehealth was reported by half of all participating hospitals and a role in stroke service coordination across their area. The exact nature of this responsibility was not reported upon, but the level of specialisation in these centres was concerning, given that some who reported the regional responsibility did not have a dedicated medical lead for stroke or even a stroke unit. Just under half these hospitals did report the use of telehealth services for acute assessment and treatment within the last year, and it is likely that these services were used to provide assistance from the larger sites and to receive assistance within the smaller sites. The impact of such telehealth support on the quality of care, particularly within smaller centres, would provide invaluable information to assist in the improvement of stroke care to patients in regional areas. 87% of participating hospitals had systems in place to coordinate their care with rehabilitation service providers and routinely carried out early assessments of rehabilitation needs using standardised tools. However, only half of all stroke patients had a documented assessment determining the need for ongoing rehabilitation. This demonstrates a significant gap in planning processes for ongoing care. Similarly, only 2/3 of all eligible stroke patients were assessed by a physiotherapist within 48 hours of their stroke. And several hospitals, including 3 large sites which admit more than 500 patients a year, did not routinely provide early assessment of rehabilitation needs. In terms of care planning and secondary prevention, stroke survivors and their families report that the transition home after stroke is a crucial time in their recovery. Comprehensive planning to facilitate this return to the community is critical. Despite this knowledge, the provision of a routine care plan for stroke patients is still unacceptably low. Only 56% of patients discharged to the community went home with a written care plan. Likewise, just 56% of patients received risk factor modification advice before leaving hospital, whilst 1/3 of ischemic stroke patients and 1/4 of hemorrhagic stroke patients did not receive recommended secondary prevention medications upon discharge. Given the high rates of recurrent stroke and the proven effects of such secondary prevention strategies in reducing this risk, these gaps in care have significant implications for both the individual and the Australian health system. Looking at TIA management and services, despite recent recommendations found in the Acute Stroke Services Framework regarding the services and systems required for effective TIA management, only 41 hospitals across Australia provided services or clinics for the assessment of TIAs within the first 48 hours. Early assessment and management of TIA is essential given the high rates of stroke early after TIA. Whilst we have no data to demonstrate how exactly these low numbers of services and clinics is translating into poor management of patients with possible TIA, there's no doubt that better access is required to manage and respond to TIA according to best practice guidelines. The results of this year's National Stroke Audit demonstrate only slight improvements in many aspects of best practice stroke care and small shifts in some indicators of acute care such as stroke unit access and care planning on discharge. Unfortunately, we continue to see many stroke patients denied access even to basic stroke unit care, and there has been no significant rise in thrombolysis rates nationally in the last 4 years. There are marked differences in the quality of care exhibited between states and also between hospitals treating different numbers of stroke patients, with general improvements as the number of stroke patients treated increase. In light of this limited improvement in the quality of stroke care across Australia, following recommendations have been made. First recommendation is to review the organisation of stroke services in each jurisdiction to ensure that more patients receive care according to the Acute Stroke Clinical Care Standard. These would include the identification of appropriate hospitals to enhance so that they do deliver all the elements of a comprehensive stroke centre. That means 24/7 thrombolysis, endovascular care, and providing access to that care to more stroke patients across the country. We also need mechanisms to increase stroke unit access, including improved bed management processes and systems to ensure all stroke patients are admitted to a stroke unit hospital, either by establishing or redistributing beds to new units or by bypassing centres without a stroke unit. The second recommendation is to appoint stroke coordinators in all stroke units nationally, with a focus on ensuring all stroke patients are admitted to the stroke unit through improved bed management processes, and also facilitating the delivery of high quality care, including discharge planning, such as care planning, and also the implementation of secondary prevention medication. Another role for the stroke coordinator is supporting the routine monitoring of stroke care so that we're monitoring and auditing against those care processes. We need to develop other multidisciplinary processes in order to support higher rates of care planning and secondary prevention management. We need to drive greater improvements in the quality of stroke care by enhancing the way in which stroke care is monitored. This can be done by reporting more regularly on the 7 quality statements in the Acute Stroke Clinical Care Standard. So I hope that's been of use in summarising the results of the National Stroke Foundation's Acute Audit for 2015. Clearly, although there have been some improvements, we need to work a lot harder in making sure that we do everything that we know works for these patients and delivering the best quality care. Thank you very much.